Most people who train consistently for 5, 10, 15 years still end up with chronic back pain, a shoulder that clicks on every press, knees that ache going downstairs, and hips so tight they can barely tie their shoes. And here is the strange part. Most of those people are not lazy. They train hard, they show up, they put in the work, and yet their bodies are slowly falling apart. The reason for that is not a lack of effort. The reason is that they have been training the muscles they can see in the mirror and completely neglecting the ones that actually hold the whole system together. Today, we are going to change that entirely. Welcome to the Huberman Lab podcast, where we discuss science and science-based tools for everyday life. I am Andrew Huberman, and I am a professor of neurobiology and ophthalmology at Stanford School of Medicine. Today's episode is about something I consider genuinely essential, and I want to be very clear about who this is for before we go any further. This is for everyone. This is for the teenager who just started lifting and wants to do it right from the beginning. This is for the person in their 20s or 30s who has been training for years and is starting to notice small aches and pains accumulating. This is for the person in their 40s and 50s who wants to know how to keep making progress without breaking down. And this is absolutely for the person in their 60s, 70s, 80s, and beyond who wants to remain strong, mobile, and completely independent. This is one of the most important topics I have covered on this channel. And I say that having covered sleep, dopamine, stress, hormones, and many other areas, because all of those things matter enormously, but none of them matter if you cannot move well and without pain. Here is what we are going to cover today. We are going to start with the foundational science of how muscle and connective tissue actually adapt, because if you do not understand the difference between how muscles respond to training and how tendons and ligaments respond, you will keep making the same structural errors most trainees make. Then we are going to do a deep dive on 4 major categories of often overlooked muscles: the glutes, the rotator cuff and shoulder stabilizers, the deep neck muscles, and the foot and ankle complex. I am going to explain the anatomy, the function, what goes wrong, and the science behind why. Then we are going to go into the specific protocols, the exact exercises, the sets, the reps, the progressions, and how to organize all of this within a real-world training schedule. We are going to talk about back pain and hip pain and why the treatment of those conditions almost always fails because people are treating the symptom rather than the source. And then we will close with cardio, fat loss, nutrition, and how to maintain excellent progress when life constraints are real and your training time is limited. Timestamps are in the description below, so please feel free to navigate directly to any section that is most relevant to you right now. Before we get into the science, I want to briefly thank our sponsors who make this content possible at zero cost to you. Without further ado, let's dive in. I want to start with what I think is the most fundamentally misunderstood aspect of training for the human body over the long term, and that is the difference between training for performance and training for structural integrity. These are not the same thing. And for most people, most programs, and most fitness culture, that distinction is either not understood or actively ignored. The conventional fitness model is almost entirely organized around outputs. How much can you lift? How fast can you run? How lean can you get? How big are your muscles? And I understand the appeal of that. Outputs are measurable. They are rewarding. They motivate you to show up. But outputs only tell you what the system produced. They tell you very little about the health of the system that is producing them. Think about a high-performance engine. You can tune an engine for maximum power output. You can get extraordinary horsepower and acceleration. But if you do that without maintaining the supporting systems, the cooling, the lubrication, the structural components that distribute the forces generated, you are going to destroy that engine over time. The human musculoskeletal system is exactly the same. You can train your primary movers, your quadriceps, your pectorals, your deltoids, your biceps to an impressive level of strength and size. But if the structural support system, the stabilizers, the connective tissue, the proprioceptive neural network, if those systems are not trained proportionally, you are accumulating a structural debt that will eventually come due. And when it comes due in the form of injury, pain, and in many cases, forced periods away from training that undo years of progress. Let me give you the physiology of why this happens, because understanding the mechanisms is what allows you to build a genuinely intelligent training approach. The first mechanism is the difference in adaptive timelines between muscle and connective tissue. Skeletal muscle is metabolically active. It has an excellent blood supply. When you stimulate muscle with training, it responds relatively quickly. Within 6 to 8 weeks of consistent resistance training, measurable hypertrophy and strength gains are occurring. Connective tissue is different. Tendons, ligaments, the joint capsule, fascial tissue, these structures are relatively avascular. They do not have the same density of blood vessels as muscle. Nutrients and inflammatory mediators and growth factors reach them primarily through diffusion from surrounding tissues and through direct mechanical loading, which stimulates tenocyte activity, meaning the cells within tendons that synthesize and remodel collagen. The key research group here is the Copenhagen group, led by Dr. Michael Kier and Dr. Peter Magnuson, who have done extraordinary work using isotopic labeling techniques to measure collagen synthesis in human tendons in response to loading. What their work shows, published in journals including the Journal of Applied Physiology and Connective Tissue Research, is that tendon collagen synthesis responds to mechanical loading, but that meaningful structural adaptation in tendons takes months, not weeks. Somewhere between 3 and 6 months for initial structural changes and much longer for full adaptation to significantly increased loads. That timeline mismatch is the source of the problem. You can get substantially stronger in a few months. Your tendons and ligaments take much longer to keep up. And in that gap, you are training in a window where your muscles can generate forces that your connective tissue is not yet equipped to handle safely. This is why injury rates are so high in people who make rapid jumps in training volume or intensity, and why even very experienced lifters who have been away for a few months due to illness or travel or life circumstances need to build back up gradually, even when their muscular strength comes back quickly. The connective tissue does not reconsolidate at the same rate the muscle strength returns. The second foundational mechanism I want you to understand is the role of the nervous system in joint protection. And this is where my background in neuroscience becomes directly applicable to what we are discussing. The nervous system has a sophisticated and largely unconscious system for protecting joints. It works through specialized sensory receptors embedded in muscles, tendons, and joint capsules. In muscles, you have muscle spindles, which are sensory organs that detect changes in muscle length and the rate of length change. They are the primary mediators of the stretch reflex. You tap your patellar tendon in your quadriceps, stretches and reflexively contracts. That is the muscle spindle in action. In tendons, you have Golgi tendon organs, which detect force and when force exceeds a threshold, cause the muscle to relax to protect against tearing. And in joint capsules and ligaments, you have Ruffini endings, Pacinian corpuscles, and free nerve endings that detect position, pressure, and pain. Together, these receptors provide constant feedback to the spinal cord and brain about where your joints are in space, how much load they are under, and whether that load is within safe parameters. This sense, the sense of your own body position in space, is called proprioception. And what the research very clearly shows is that proprioceptive acuity is trainable and that impaired proprioception is one of the primary risk factors for both acute and chronic musculoskeletal injury. Studies from groups at the University of North Carolina and elsewhere have shown that athletes who have suffered ankle sprains have significantly reduced proprioceptive acuity at the ankle compared to uninjured controls, and that this reduced proprioception persists long after the structural injury has healed. The joint feels fine, but the neural protection system has been compromised. And that is why ankle sprain recurrence rates are so high. It is not that the ligament did not heal. It is that the sensory system that would have prevented the initial sprain is now less sensitive than it should be. The good news is that proprioceptive training restores this capacity. Balance training, single leg work, controlled perturbation training, end range joint loading under low load conditions, all of these train the proprioceptive system and reduce injury rates. Research published in the British Journal of Sports Medicine has shown that proprioceptive and neuromuscular training programs reduce the rate of ankle injury by approximately 40 to 50% in both sport and occupational settings. Those are remarkable numbers. The third mechanism is tension through range of motion. This is a concept that has become much clearer in the research literature over the past decade. Muscles grow and get stronger primarily in the range of motion in which they are trained. This is one expression of the principle of specificity, which is one of the most robust and reproducible findings in all of exercise science. What this means in practice is that if you consistently train with partial range of motion, you will develop strength and structural capacity in that partial range, and you will remain relatively weak and unprotected at the extremes of your joint range. The problem is that injuries do not occur in the comfortable mid-range of joint motion. Injuries occur at end ranges, often under unexpected load. If your muscles and tendons have never been trained at those positions, they are not equipped to handle the forces that can occur there. Research from Brad Schoenfeld's group and others has demonstrated that full range of motion training produces greater hypertrophy, particularly in the long head of the biceps, the hamstrings, and the gluteus maximus compared to partial range of motion training. And mechanistically, this makes sense because training at longer muscle lengths, meaning the stretch position, maximizes the contribution of titin, which is a giant structural protein inside muscle fibers that contributes to passive force and to myofibrillar signaling for hypertrophy in the stretched position. This means that fully stretched positions under load are particularly potent stimuli for both muscle growth and connective tissue adaptation. Deep squats, full range Romanian deadlifts, full range pull downs, chest flies taken to full pectoral stretch. These are not just range of motion cues for form. They are loading the biological mechanisms that build structural resilience. Now let's go into the specific muscle groups that are most commonly undertrained and that have the most significant consequences when neglected. I am going to cover 4 major areas in depth. And for each one, I am going to give you the anatomy, the biomechanical function, the consequences of weakness, and the preview of how to address it. The glutes are first, and they deserve the most time because they are involved in more injury patterns than any other muscle group we are going to discuss. The gluteal complex consists of 3 muscles. The gluteus maximus, which is the largest muscle in the human body and the primary hip extensor. The gluteus medius, which is on the lateral aspect of the hip and whose primary functions are hip abduction and frontal plane pelvic control. And the gluteus minimus, which lies deep to the medius and assists with abduction and internal rotation. Most programs address the gluteus maximus to some degree, at least in compound movements like squats and deadlifts, though usually not as well as they could. The gluteus medius and minimus are almost universally neglected, and this is a problem for a very specific reason. Think about what happens every time you take a step. For the fraction of a second that you are on one leg, your entire body weight plus the ground reaction force from impact has to be supported by that single limb. The pelvis, which is connected to both legs, has a strong tendency to drop toward the non-weight-bearing side because of gravity. The structure that resists that drop is the gluteus medius of the weight-bearing leg. It fires to hold the pelvis level. If it is weak, the pelvis drops on the swing side. And when the pelvis drops, a cascade of compensatory biomechanics occurs. The femur of the stance leg internally rotates. The knee of the stance leg moves into valgus, which means it caves inward. The tibial external rotation relative to the femur is lost. The patella tracks laterally relative to the femoral groove. And the IT band, which connects the iliac crest to the tibia, becomes excessively tensioned. What you get clinically is patellofemoral pain syndrome, iliotibial band syndrome, and frequently hip bursitis or greater trochanteric pain syndrome, all from one weak muscle. This specific pattern, where the pelvis drops on the non-weight-bearing side during single leg stance, is called the Trendelenburg sign, named after the German surgeon Friedrich Trendelenburg, who first described it in the 19th century. It is one of the most common clinical findings in patients with hip pain, knee pain, and low back pain. And the treatment, when properly identified, is remarkably straightforward. Strengthen the gluteus medius. The additional complication is that most people who live modern sedentary lives have gluteal inhibition from chronic hip flexor tightness. When you sit for extended periods, the hip flexors, particularly the iliopsoas, are in a shortened position. Adaptive shortening occurs over months and years. And when a muscle is chronically shortened on one side of a joint, it creates what is called reciprocal inhibition of the antagonist on the other side. The central nervous system, through interneuronal circuits in the spinal cord, reduces motor output to the antagonist muscle when the agonist is activated. This is a normal and useful reflex under normal conditions. But when one muscle is chronically overactive due to postural habit, it results in chronic inhibition of the opposing muscle. So tight hip flexors from sitting literally reduce the neural drive to your glutes. This is why many people feel almost nothing in their glutes during exercises that should be training them. The neural connection has been attenuated, and this has to be addressed directly before you can effectively load the glutes. The rotator cuff is the second major target. Let me explain the biomechanics precisely, because I think most people have a vague sense that the rotator cuff is important, but do not really understand why. The shoulder is the most mobile joint in the human body. That mobility is possible because the socket, the glenoid fossa, is very shallow relative to the size of the humeral head, the ball. Some have described it as a golf ball sitting on a tee. This architecture allows enormous freedom of movement, but provides minimal structural stability from the bony geometry itself. The structures responsible for keeping the humeral head centered in the glenoid are the joint capsule, the glenoid labrum, which is a fibrocartilaginous rim that deepens the socket slightly, and the rotator cuff muscles. The rotator cuff consists of four muscles: the supraspinatus, which abducts the arm and helps initiate shoulder elevation, the infraspinatus and teres minor, which externally rotate the humerus, and the subscapularis, which internally rotates the humerus. During virtually all shoulder movements, these four muscles fire in a coordinated sequence to compress the humeral head into the glenoid, maintaining joint congruency as the larger prime movers generate force. When the rotator cuff is weak, or when its activation timing is disrupted, the humeral head does not stay perfectly centered during movement. Under the forces generated by pressing and overhead movements, it migrates superiorly and anteriorly. Superiorly, it impacts the supraspinatus tendon and the subacromial bursa against the underside of the acromion, the bony arch formed by the clavicle and the scapular spine above the shoulder. This is subacromial impingement. Over time, repeated mechanical compression causes inflammation, degeneration, and eventually structural damage to the supraspinatus tendon. This is how most rotator cuff tears begin. They are not traumatic in origin. They are the accumulation of years of repetitive microtrauma from a joint that was never properly stabilized. And the data on this are remarkable. Research from the Journal of Shoulder and Elbow Surgery using MRI imaging has found that partial or full thickness rotator cuff tears are present in approximately 34% of individuals over 60 years old who have never had a shoulder injury. In people who have trained heavily with pressing movements without adequate rotator cuff work, those numbers are higher and occur at younger ages. The ratio I want you to remember is this. For every set of horizontal pressing, which includes all bench press variations, you want at least 2 sets of horizontal pulling. For every set of overhead pressing, you want at least 2 sets of vertical pulling plus dedicated external rotation work. This is not just a ratio for avoiding injury. It is a ratio for optimal shoulder function and long-term shoulder health. The pressing movements bias the internal rotators and anterior deltoid. Without compensatory work for the external rotators and posterior shoulder musculature, the shoulder eventually develops structural and functional asymmetry that results in pain and impingement. The deep neck musculature is the third category. The cervical spine is a marvel of evolutionary engineering. It has to be simultaneously rigid enough to support the 10 to 12 pounds of your skull and flexible enough to allow you to look in nearly any direction. It accomplishes this through a complex arrangement of small intrinsic muscles, ligaments, and 7 cervical vertebrae. The muscles I want to focus on are the deep cervical flexors, specifically the longus colli and longus capitis, which run along the anterior surface of the cervical spine, and the deep cervical extensors, including the semispinalis cervicis and the multifidi, which run along the posterior surface. These deep muscles perform a role in the cervical spine that is directly analogous to what the transverse abdominis and multifidi do for the lumbar spine. They are the segmental stabilizers. They do not generate large movements. They provide precise moment-to-moment postural control and protect the intervertebral joints during load. When they are weak, the superficial global muscles, the sternocleidomastoid anteriorly and the upper trapezius and levator scapulae posteriorly, compensate, and when those superficial muscles are chronically overactive, you get the pattern of tension, pain, and dysfunction that is ubiquitous in people who spend significant time at desks and screens. Forward head posture, which is the common consequence of this pattern, is not just aesthetic. The physics are straightforward and the numbers are sobering. Research from Dr. Kenneth Hansraj, published in Surgical Technology International, modeled the forces on the cervical spine at various degrees of head flexion. At neutral posture, the cervical spine supports roughly 10 to 12 pounds. At 15 degrees of forward flexion, the effective force increases to about 27 pounds. At 30 degrees, approximately 40 pounds. At 45 degrees, approximately 49 pounds. At 60 degrees, which is the typical angle of looking at a phone in your lap, the effective load on the cervical spine is approximately 60 pounds. The cervical extensors are dealing with 6 times the load they would face in neutral posture. Over hours of daily exposure across years and decades, the cumulative mechanical stress on the posterior cervical structures is enormous. This is why cervicogenic headaches, which are headaches that originate from cervical structures rather than from within the brain, are so prevalent. The World Health Organization estimates that tension-type headaches and cervicogenic headaches affect the majority of adults and represent an enormous burden of chronic pain globally. And the musculoskeletal basis of a very large proportion of those headaches is directly addressable through the neck strengthening and postural work we are going to discuss. The foot and ankle is the fourth category. I want to make the case that this is the most structurally foundational area of the body and also the most neglected. The foot is astonishingly complex. 26 bones, 33 joints, over 100 muscles, tendons, and ligaments in each foot. The longitudinal arch of the foot, which most people have at least a vague awareness of, is not simply a structural arch like the arch of a bridge. It is a dynamic, spring-loaded structure that stores and returns elastic energy with every step. The plantar fascia provides the passive tensioning element of this spring mechanism. The windlass mechanism and the intrinsic and extrinsic foot muscles provide active control of the arch under varying load conditions. When these muscles are strong and the arch is well controlled, the foot efficiently absorbs ground reaction forces and transmits them upward through the kinetic chain in a controlled fashion. When the intrinsic foot muscles are weak, the arch collapses under load, a process called excessive pronation, and as with every failure in the kinetic chain we have discussed, this collapse does not stay local. Excessive pronation causes the talus to internally rotate. The internal rotation of the talus causes internal rotation of the tibia. The internal tibial rotation creates a valgus stress at the knee. The valgus stress at the knee alters hip mechanics. So weakness in the intrinsic muscles of the foot directly contributes to knee pain, hip pain, and even low back pain through this mechanical cascade. Research published in the Journal of Orthopedic and Sports Physical Therapy has demonstrated clear kinematic links between foot pronation and patellofemoral joint stress, IT band tension, and hip abductor loading. The foot is not an isolated structure. It is the foundation of everything above it. The additional problem is that modern footwear, with its cushioning and arch support, is simultaneously protective in acute terms and weakening in long-term terms. A cushioned motion control shoe reduces ground reaction force and controls excessive pronation from the outside, but it also reduces the mechanical challenge to the intrinsic foot muscles. Over years of wearing supportive footwear, these muscles atrophy from disuse. When you then ask the foot to function under higher demands during barefoot activities, during athletic movements, or simply in less supportive footwear, the intrinsic muscles are not equipped to provide adequate support and injury results. This is not an argument against wearing supportive shoes. There are contexts where they are appropriate and valuable. It is an argument for supplementing whatever footwear you use with specific intrinsic foot muscle training. Now I want to lay out the protocols. These are specific, evidence-based interventions you can begin implementing immediately. I am going to organize these by the 4 target areas we just discussed, and then I am going to add sections on back and hip pain specifically, followed by cardio, fat loss, and nutrition. As with everything I share, this is not medical advice. If you have existing injury, pain, or any underlying health condition, please consult with a qualified sports medicine physician or physical therapist before beginning new exercises. Before any lower body training session, you need to address the reciprocal inhibition from hip flexor dominance. This is a 3 to 5 minute investment that will meaningfully change how much your glutes actually contribute to your subsequent training. The most effective intervention I know is the half-kneeling hip flexor stretch combined with active glute engagement. Get into a lunge position with one knee on the ground and the other foot forward. Tuck your pelvis posteriorly, meaning perform a slight posterior pelvic tilt by contracting your glute on the kneeling side. Without losing that pelvic tuck, lean your torso slightly forward. You should feel a deep stretch in the anterior hip of the kneeling side. Hold for 30 to 45 seconds per side. The reason the pelvic tuck matters is that simply getting into the lunge position does not maximally lengthen the iliopsoas. You have to posteriorly tilt the pelvis to bring the proximal attachment of the hip flexor into its fully lengthened position. Research on proprioceptive neuromuscular facilitation, specifically the contract-relax technique, suggests that following the stretch with a brief isometric contraction of the hip flexor followed by active relaxation can further enhance the stretch. So after your hold, press your back knee gently into the floor to create a gentle isometric hip flexor contraction. Hold 3 seconds, release, and try to deepen the stretch. The primary glute activation exercise I want you to do before loading the glutes is the side-lying clamshell with a resistance band placed just above the knees. Lie on your side, hips stacked at approximately 45 degrees of flexion, knees bent to 60 degrees, feet together. Keep the pelvis completely still and open the top knee toward the ceiling. The critical cue is this: do not let the pelvis roll backward as the knee opens. The pelvic roll is the primary compensation, and it completely shifts the work away from the gluteus medius and onto the hip external rotators and hip flexors. Put your hand on your top hip to monitor for any pelvic movement. 15 to 20 repetitions per side. By the end of the set, you should feel significant fatigue and burning in the lateral hip, the gluteus medius. If you do not feel it there, you are compensating. For primary glute strength development, the hip thrust is the most important exercise in this protocol. Research from Brett Contreras and his colleagues, published in the Journal of Strength and Conditioning Research, using surface electromyography, has consistently demonstrated that barbell hip thrusts produce the highest peak and mean gluteus maximus EMG activation of any exercise tested, including squats and deadlifts. The reason is that the hip thrust loads the gluteus maximus at its shortest position, at full hip extension, which is where the gluteus maximus is the primary active contributor. In squats and deadlifts, the glute contribution is highest near the top, but the movement continues from the bottom and the load on the glute is shared with the quadriceps throughout the range. In the hip thrust, the glutes are isolated as the primary driver at the top of the movement. Set up with your shoulders on a bench, barbell across the hips with a barbell pad for comfort, feet flat at approximately hip width with toes turned out slightly. Drive through the heels, extend the hips to full extension, squeeze the glutes hard at the top for a 1 to 2 second isometric pause, then lower under control. 3 to 4 sets of 8 to 15 repetitions with load that is genuinely challenging in the last few reps. Progress the load over weeks and months. For the gluteus medius, in a loaded context, the single leg Romanian deadlift is the highest value exercise I know of. It simultaneously trains the hip extensors and hamstrings eccentrically, develops single leg stability, and provides significant proprioceptive challenge to the hip, knee, and ankle. Stand on one leg, hold a dumbbell or kettlebell in the opposite hand, and hinge at the hip while keeping the pelvis level, the spine neutral, and the standing knee soft. Lower until you feel maximal hamstring tension, approximately a 45 to 90 degree torso inclination, depending on your hamstring flexibility. Then drive back up through the heel. The key mistake is letting the pelvis rotate, dropping the hip on the free leg side. This is the Trendelenburg pattern, and it means the gluteus medius is not doing its job. Use a light enough load that you can maintain a level pelvis throughout, 2 to 3 sets of 8 to 12 per leg. The lateral band walk is the third glute medius exercise I recommend. Place a resistance band just above your ankles or just below the knees. Take a slight quarter squat position and walk laterally in both directions while maintaining that position and keeping the toes forward. The resistance from the band challenges hip abduction throughout the gait cycle on both sides simultaneously. Do 10 to 15 steps per direction for 2 to 3 sets. The first exercise is side-lying external rotation. This directly targets the infraspinatus and teres minor, the primary external rotators of the humerus. Lie on your side with your elbow bent to 90 degrees and your upper arm against your body. Hold a light dumbbell in the top hand. Without letting the elbow drift away from the side of your body and without shrugging the shoulder upward, rotate the forearm toward the ceiling. The range of motion is from forearm parallel to the floor, pointing forward, to forearm perpendicular to the floor or slightly beyond, pointing up. The movement is pure external rotation with no other shoulder motion. Use a weight that allows 15 to 20 clean repetitions. Most people who have not specifically trained this will find 5 pounds is challenging initially. Do not let the ego interfere here. The rotator cuff muscles are small and have no business handling the same loads as your prime movers. 2 to 3 sets of 15 to 20 repetitions per side progress slowly over months. The face pull is the second essential exercise, and it is one of my absolute favorites for shoulder health. It can be done with a cable machine set at face height or slightly above, or with a resistance band anchored at the same height. You pull the handles toward your face with your elbows high and wide, ending with your hands beside your ears and your elbows fully externally rotated. Think about pulling your elbows behind you as much as pulling your hands toward your face. This position at the end range, with the shoulder in external rotation and the elbows high, maximally activates the posterior deltoid, the infraspinatus, the teres minor, and the lower and middle trapezius. It directly counteracts the internal rotation, forward head, and rounded shoulder posture that bench pressing and prolonged sitting create. Do face pulls at least 3 times per week. 2 to 3 sets of 15 to 20 repetitions. You can perform these between your pressing sets as an antagonist superset, which has the added benefit of reducing recovery time and maintaining shoulder health during high volume upper body training days. The prone Y, T, and W series is the third component. Lie face down on a bench, incline to approximately 30 degrees if possible, with your arms hanging down. For the Y, raise both arms up and slightly out at a 30-degree angle from overhead, thumbs pointing up, hold briefly and lower. For the T, raise both arms straight out to the sides, again with thumbs up, hold and lower. For the W, bend your elbows and raise them while simultaneously externally rotating the forearms, creating a W shape. Hold and lower. These exercises target the lower trapezius, rhomboids, and posterior rotator cuff in a manner that directly trains scapular retraction, depression, and posterior tilting, all of which are critical for healthy shoulder mechanics during overhead activities. Begin with no external load. The weight of your arms will be sufficient for many people. 2 to 3 sets of 10 repetitions in each position. Progress to very light dumbbells, 2 to 5 pounds, only when body weight feels genuinely easy. The foundational exercise for deep cervical flexor strength is the chin tuck, also called cervical retraction. Stand or sit with your back against a wall. Without tilting your chin up or down, gently retract your head backward until the back of your head makes contact with the wall or comes close to it. The sensation is of making a double chin. Hold this position for 10 seconds. Release gently. Repeat 10 times. This seems deceptively simple. Do it correctly, and you will feel the deep anterior neck muscles working. The superficial muscles, the sternocleidomastoid, which runs from behind your ear to your collarbone, should not be significantly activated. If you see or feel that muscle bulging prominently, you are using too much force and substituting superficial for deep muscle activation. The goal is a gentle, controlled retraction. Do 2 to 3 sets of 10 repetitions with 10-second holds daily. This is genuinely one of the highest value 5-minute investments you can make in your cervical spine health. The deep neck flexor endurance test, which can also be used as a training exercise, is performed lying on your back. Tuck your chin slightly, as if nodding, and lift your head just 1 to 2 centimeters off the ground. Maintain this position for as long as you can while keeping your chin tucked and your gaze straight up, not forward. When you lose the chin tuck and your head extends so the chin points up, you have fatigued the deep flexors and the superficial sternocleidomastoid has taken over. Stop there. A normal value for healthy individuals is 30 to 60 seconds. Patients with chronic neck pain typically score less than 20 seconds and often less than 10. Work toward 30 seconds of clean chin tucked hold. Train this 3 times per week. For the cervical extensors and overall cervical strength, resistance band work is appropriate for most healthy individuals without structural cervical pathology. The simplest version uses a resistance band anchored at approximately head height in front of you. Place the band around the circumference of your head and step backward until there is tension pulling your head forward. Resist this pull, maintaining your head in neutral. Hold for 10 seconds. Repeat 10 times. You can perform variations with the band pulling from different directions to train lateral flexion and rotation resistance as well. As with all neck training, start with very low resistance. The cervical spine is not a region to apply the progressive overload principles you use for large muscle groups. The goal is endurance and control, not maximum strength. Short foot exercise is the foundational drill for intrinsic foot muscle activation. Stand barefoot. Without curling your toes downward, attempt to shorten the length of your foot by drawing the ball of your foot toward your heel. The arch should rise slightly as the intrinsic muscles contract. Do not use your toes to grip the floor. The activation should come from the muscles of the arch itself. Hold for 5 seconds, fully relax, and repeat 10 times. This is neurologically demanding at first because these muscles have been dormant in most people who have grown up wearing supportive footwear. Begin with 2 feet on the ground. Progress to single leg only when you can consistently feel the intrinsic muscles activating clearly. Practice this daily, ideally in the morning and again in the evening. The single leg eccentric calf raise is the second and perhaps most important exercise for foot, ankle, and lower leg resilience. Stand on one foot at the edge of a step with your heel hanging off the edge. Lower your heel as slowly and as far as possible to maximum dorsiflexion over 3 to 4 seconds. Then rise on both feet to take some load off the eccentric phase and repeat. This exercise trains the gastrocnemius, the soleus, and critically the Achilles tendon complex through the full range of motion under load. The research from Håkan Alfredsson's group, which first established the eccentric calf raise protocol for Achilles tendinopathy, and subsequent work from multiple groups, has shown this to be among the most evidence-supported interventions for both treating and preventing Achilles and calf pathology. Begin with body weight only. Progress to a loaded vest or a dumbbell held on the same side as the working leg. 3 sets of 15 repetitions per leg, performed 3 times per week. Single leg balance work is the third element, and it trains the proprioceptive system of the ankle and foot directly. Begin standing on one leg with your eyes open and attempt to hold perfect balance for 30 seconds per side. When this is easy, close your eyes. Vision provides significant proprioceptive input to the balance system, and removing it forces the ankle and foot proprioceptors to bear more of the stabilization load. When single leg balance with eyes closed is stable for 30 seconds, progress to a slightly unstable surface, such as a folded towel or a balance pad. Research published in the British Journal of Sports Medicine has shown that neuromuscular training programs, including this type of balance work, reduce ankle sprain incidence by approximately 30 to 50% in both athletic and general populations. I want to be very direct about something. Most people with chronic low back pain, which affects approximately 80% of adults at some point in their lives, have been told to rest, to take anti-inflammatories, and to avoid activities that aggravate the pain. And while acute pain management is important, this approach fundamentally fails to address the root cause and is a significant driver of the transition from acute pain to chronic pain. The majority of non-specific low back pain, meaning pain without a fracture, tumor, infection, or clear structural nerve compression, originates from dysfunctional load transfer through the lumbar spine due to inadequate deep core stability, impaired hip mechanics, or both. The treatment is not rest. The treatment is appropriately dosed, carefully selected exercise. The McGill Big 3 protocol, developed through decades of research by spine biomechanist Dr. Stuart McGill at the University of Waterloo is the most evidence-supported exercise framework for both acute and chronic low back pain management. These 3 exercises train the deep core stabilizers without subjecting the lumbar discs to excessive compressive load. The modified curl-up, lie on your back with one knee bent and one straight, hands placed under the lumbar curve to maintain the natural lordosis. Lift only your head and upper shoulders off the ground, chin tucked, while maintaining the lumbar curve. Do not flatten your lower back into the ground. Hold for 10 seconds. Repeat 10 times. Switch the bent and straight leg after each set. The side bridge, lie on your side with your weight on your elbow directly beneath your shoulder and your feet stacked. Lift your hips, creating a straight line from head to ankles. Hold 10 seconds. Lower and repeat 10 times. Beginners can modify by keeping both knees on the ground rather than feet stacked. The bird dog, on all fours with a neutral spine, simultaneously extend one arm straight forward and the opposite leg straight back, maintaining perfect spinal neutrality. Hold 10 seconds. Return to the start and repeat on the other side. 10 repetitions per side. Research from McGill's lab, published in the journal Spine, among others, has validated these exercises as producing significant activation of the deep core stabilizers, particularly the multifidus, while maintaining low lumbar disc compression forces compared to exercises like crunches, sit-ups, or loaded flexion movements. For hip pain, particularly anterior hip pain, snapping hip syndrome, and lateral hip pain, including greater trochanteric pain syndrome, the approach almost always includes gluteus medius strengthening, hip flexor lengthening, and correction of the hip hinge movement pattern. The hip hinge deserves specific attention because so many people have lost the ability to do it correctly. The hip hinge is the movement of pushing the hips backward while maintaining spinal neutrality, with the knees bending slightly, but the primary motion occurring at the hips. It is the basis of the deadlift, the Romanian deadlift, the kettlebell swing, and the good morning. And when done incorrectly with lumbar flexion rather than true hip hinge, these movements place excessive compressive and shear load on the lumbar discs. The most effective cue I have encountered for teaching the hip hinge is this. Stand with your back to a wall approximately 1 foot away. With a slight bend in the knees, push your hips backward until they contact the wall while keeping your chest up and your spine long. That is a hip hinge. Practice it 10 to 15 times per session until it is automatic. Then practice it with a dowel or a broomstick along your spine with 3 contact points: the back of the head, the middle of the upper back, and the sacrum. All 3 should maintain contact with the dowel throughout the movement. This gives you real-time proprioceptive feedback on whether you are maintaining spinal neutrality or hinging correctly. Cardiovascular training in the context of this structural approach to fitness should be considered not just as a tool for heart health and body composition, but as a stimulus for metabolic and connective tissue adaptations that support everything else we are discussing. Zone 2 cardio, which I defined earlier as the intensity at which you can maintain a conversation but are breathing more heavily than at rest, correlates approximately to 60 to 70% of your maximum heart rate and is the intensity at which oxidative metabolism predominantly drives energy production. Research from Dr. Inigo San Millan, exercise physiologist and coach to several World Tour cycling teams, and from groups including those of Dr. Edward Coyle at the University of Texas, has established that Zone 2 training is the primary driver of mitochondrial density in skeletal muscle, improvements in fat oxidation capacity, cardiovascular efficiency, and lactate clearance capacity. The practical recommendation from the evidence base is approximately 150 to 200 minutes of Zone 2 cardio per week, divided across at least 3 sessions. For most people, this looks like 30 to 40 minutes of brisk walking, light cycling, easy swimming, or light jogging 4 to 5 times per week. The intensity should feel sustainable. You should feel like you could continue indefinitely. If you are breathing too hard to speak in full sentences, you are above Zone 2. This is not heroic effort training. It is steady, consistent, aerobic base building that pays enormous dividends over months and years. For fat loss in the context of training for structural resilience, the most important dietary variable is protein intake. The research on this is extremely clear and extremely consistent. A meta-analysis published in the British Journal of Sports Medicine reviewing 49 studies found that protein supplementation significantly increased fat-free mass gains during resistance training, optimal daily protein intake for people who are training and who want to maintain or build lean tissue, whether in a caloric surplus or a caloric deficit, appears to be approximately 1.6 to 2.2 grams of protein per kilogram of body weight per day. This is substantially higher than the recommended dietary allowance, which was set based on the minimum needed to prevent deficiency, not the optimal amount for training adaptation. For a person who weighs 75 kilograms, about 165 pounds, this means 120 to 165 grams of protein per day, distributed across 3 to 4 meals with at least 30 to 40 grams of high-quality protein, meaning complete protein containing all essential amino acids, in each meal. High-quality protein sources include eggs, meat, fish, dairy, soy, and high-quality protein powders such as whey, casein, or pea protein. Leucine, which is one of the branched-chain amino acids, appears to be particularly important as the trigger for muscle protein synthesis. Foods and supplements high in leucine include whey protein, eggs, and animal protein sources broadly. Regarding total caloric intake for fat loss, a modest caloric deficit of 250 to 500 calories per day below maintenance is sufficient to produce meaningful fat loss without significantly impairing muscle protein synthesis or training recovery. Aggressive deficits, particularly in the context of resistance training, tend to impair recovery, reduce training performance, and make it more difficult to maintain lean mass. The goal is to lose fat, not to just lose weight. Maintaining training volume and intensity during a caloric deficit, combined with adequate protein intake, is the evidence-based approach to preserving lean mass while reducing fat mass. Creatine monohydrate is the most well-researched ergogenic supplement available, and it has direct relevance to the topics we have discussed today. Over 200 studies have examined its effects on exercise performance. The consistent finding is that creatine supplementation at 3 to 5 grams per day increases phosphocreatine stores in skeletal muscle, which enhances the capacity to rapidly regenerate ATP during high-intensity exercise. This translates to meaningfully improved performance in sets above about 8 seconds of maximal effort and to greater total training volume capacity over a session. It also supports muscle hypertrophy. More recently, there has been emerging evidence, not yet definitive but interesting, that creatine may support connective tissue anabolism and reduce exercise-induced muscle damage. Creatine monohydrate is inexpensive, widely available, and has a very strong safety profile based on decades of research. Typical dosing is 3 to 5 grams per day without any need for loading phase. Note that creatine draws water into muscle cells, so initial weight gain of 1 to 3 kilograms is expected. This is not fat. It is intramuscular water, which actually contributes to improved exercise performance. If you have kidney disease or are on medications that affect kidney function, please consult your physician before using creatine. Now, I want to address the real-world training constraints that most people face, because I think it is important to give practical guidance that actually applies to how people live their lives. If you have 45 minutes to train and can train 3 times per week, here is how I would prioritize the structural resilience work we have discussed. In the 5 minutes before every session, do your targeted activation work. On lower body days, do the clamshells, the hip flexor stretch, and the short foot exercise. On upper body days, do the face pulls and external rotations. On all days, do the chin tuck, 10 repetitions, 10-second holds. This takes under 3 minutes and directly prepares the stabilizer systems for the training that follows. In every lower body session, include at least 1 single leg exercise. The single leg RDL is the highest value choice because it addresses the glutes, the hamstrings, proprioception, and lateral pelvic stability simultaneously. In every upper body session, maintain at least a 2-to-1 pulling to pressing ratio. For every set of bench press or overhead press, do 2 sets of rows, face pulls, or pull down variations. Do the McGill Big 3 3 times per week. Each set takes 10 seconds, 10 repetitions, and the full protocol for all 3 exercises takes under 10 minutes. This is not a large time investment relative to the injury prevention benefit. And do your foot and balance work daily, not necessarily in the gym. Stand on one leg while brushing your teeth. Practice short foot while standing at your desk. These are 5-minute daily practices that train neural systems that need frequency, not duration. Let me now address the most common mistakes I encounter, even in experienced trainees, because understanding why intelligent people consistently make these errors is the first step to avoiding them. The first and most pervasive mistake is training the anterior chain far more than the posterior chain. Most gym programs are front-loaded, literally, more chest than back, more quadriceps than hamstrings and glutes, more biceps than triceps, more anterior deltoid than posterior deltoid, and rotator cuff. This is largely driven by the fact that the muscles on the front of the body are visible in the mirror and respond visibly to training. It feels rewarding to train them. The posterior chain muscles are less visible, less glamorous, and their training is less immediately gratifying. But they are structurally more important for posture, for joint health, and for long-term pain-free function. The data from biomechanics research and from clinical populations is unambiguous. Posterior chain weakness relative to anterior chain strength is one of the most reliable predictors of musculoskeletal injury across virtually every sport and occupation studied. The solution is simple but requires discipline. Audit your current program, count your sets per week of pressing versus pulling, count your sets of quad dominant versus hip dominant lower body work. If the ratio is not at least close to 1-to-1, and ideally 2-to-1 in favor of pulling and hip dominant work, adjust it. The second mistake is training in a limited range of motion under the belief that this is safer or that partial range work is sufficient. I see this most commonly in the squat, where people quarter squat because they believe deep squatting is bad for the knees. The research does not support this belief for the vast majority of people. Research from multiple groups, including work from Dr. Antonio Vygotsky and Dr. Brett Contreras, has shown that full-range squatting produces greater gluteal and hamstring activation, greater quad hypertrophy, and does not significantly increase peak knee joint loads compared to partial squats in healthy individuals who have adequate mobility. The evidence strongly favors full range of motion training for both hypertrophy and joint health. Training the muscle only in its comfortable mid-range leaves the end ranges untrained, structurally unprepared for the forces that can occur there, and reduces the total muscle length over which hypertrophy occurs. More complete training produces more resilient tissue. The third mistake is confusing different exercise intensities with effective training. I mentioned zone 2 cardio earlier. The gray zone, zone 3, which is moderate intensity cardio that is too hard to sustain comfortably, but not hard enough to produce the high intensity adaptations from interval training, is where many people accidentally spend most of their cardio time. They go out for a jog that is harder than a walk, but easier than a run. This accumulates fatigue, is not maximally effective for aerobic-based development, and does not provide the specific adaptations of high-intensity intervals. If you have time for cardio, be deliberate about intensity. Either go truly easy enough to stay in zone 2, where you can speak full sentences comfortably, or go hard enough to be doing genuine high-intensity interval training, which means intervals where you are working close to maximal capacity for 30 seconds to 2 minutes, followed by adequate recovery. Both have significant benefits. The middle ground has fewer. The fourth mistake is treating warm-up as an afterthought. I have seen this consistently across all training populations. People arrive at the gym and within 2 minutes they are doing their working sets. The warm-up gets a few minutes of treadmill walking and 1 or 2 lighter sets of the main exercise. And that is not enough. A proper warm-up for structural resilience-focused training includes targeted mobility work for the joints being loaded, specific activation work for the stabilizers we have discussed, movement pattern rehearsal at low load, and central nervous system activation through progressive loading. This does not have to take 30 minutes. 10 to 15 minutes of deliberate preparation dramatically reduces injury risk and improves training quality. The 5 minutes of targeted activation I described is a component of this, not the entirety of it. Let me close with a synthesis of the key takeaways from today. The first is that injury resilience is a quality you build, not one you are born with. The stabilizer muscles, the proprioceptive system, the connective tissue, all of these adapt to training stimulus over time, but they require deliberate, specific attention. They will not develop adequately as side effects of training the primary movers. The second is that connective tissue adapts on a timeline of months to years, not weeks. This means you need to be patient and consistent with the loading of tendons and ligaments. The window between muscular strength and connective tissue capacity is where injuries occur, and closing that window requires long-term, progressive exposure to load. The third is that pain location almost never equals pain source. Knee pain comes from the hip and foot, shoulder pain comes from the rotator cuff and scapular stabilizers, low back pain comes from the core and glutes. Treating the symptom rather than the source is the single most common reason that chronic pain fails to resolve. The fourth is that the nervous system is a critical and trainable component of injury resilience. Proprioception, motor control, activation timing of stabilizer muscles, all of these are neural qualities that respond to appropriate training. Balance work, single leg training, and end range controlled loading are all training the neural systems that protect your joints. The fifth is that zone 2, cardio and adequate protein intake, are the foundational background conditions on which all of this structural work rests. The tissue repair and adaptation that comes from training depends on protein synthesis, which depends on adequate protein intake, and the mitochondrial and cardiovascular infrastructure to support consistent training depends on aerobic base development. The sixth and final takeaway is that you can do all of this within real-world time constraints. The exercises I have given you today do not require hours per day. They require deliberate minutes and consistent frequency. 5 minutes of activation before every session, 10 minutes of McGill protocol 3 times per week. Daily balance and footwork during activities you are already doing. 1 single leg exercise per lower body session. A pulling to pressing ratio of at least 2-to-1. These are additions and adjustments to what you are likely already doing, not a complete overhaul that requires starting over. All of the studies and researchers I mentioned today are linked in the description below. If you want to go deeper on any of these topics, the episode descriptions contain extensive reading lists. The newsletter and the daily blueprint are also linked below for those who want a more detailed breakdown of my personal protocols. If you found today's episode valuable, please subscribe to this channel, share it with someone who could benefit, and please consider leaving a review on whichever platform you use to listen to the podcast. Your support allows us to continue producing this content at zero cost to you. Thank you for your time and for your investment in your own health and longevity. And as always, thank you for your interest in science.